Hello, and welcome to my talk on transplant renogram interpretation. Let's start off by thinking about why we perform the transplant renogram. Well, we want to do a MAG3 scan when we want to evaluate the function, look for complications, and treatment monitoring of the transplant, renal transplant. We used to do it for assessing the baseline function, but we don't do that anymore. But we still perform the MAG3 when we are following up any complications of the renal transplant. So we can use the MAG3 to evaluate the vascular perfusion. We can look for causes or evidence of graft dysfunction. We can evaluate the any peritransplant fluid collections, looking for any urine leaks. We can look for urological complications such as ureteric strictures, and the MAG3 also gives us prognostic information regarding the graft survival. There are a few key differences between the transplant MAG3 and the native kidneys. Most importantly, we're scanning anteriorly. We use the iliac vessels for our blood pool reference, and we usually don't give a diuretic except if we're specifically looking for obstruction. You also only have one kidney to evaluate, except in some cases you might have a dual kidney transplant, such as this. How do we do it? Well, the interpretation of the transplant renogram is identical to the native kidneys. We have three phases. We start off with a perfusion phase. So we don't tend to use Hilson's perfusion index anymore when we're evaluating the transplant kidneys, and this is because most of the work was based on DTPA and also serial scanning, often with a baseline scan done immediately post-operatively. So we find now that a single MAG3 with a perfusion index is not that useful. However, it's worth being aware of how the perfusion index is calculated, because I use that when I'm visually assessing the flow curves. So for instance, just as a reminder, the perfusion index is actually a ratio of the area under the curve of the transplant over the area under the curve of the, compared to the area under the curve of the iliac artery up to the peak activity in the iliac artery. And these two areas and these two curves should be very closely aligned and should overlap. But you need to be aware that if the scan has been started late and you've missed the initial flow images, you're not going to be able to interpret the perfusion. Also, it's important to know that the perfusion on the MAG3 can't differentiate ATN from rejection, and it can't diagnose arterial stenosis. When you're looking at perfusion, you should look for the heterogeneity within the transplant kidney. You should compare this with the vascular anatomy, so it's important to know how many transplant arteries there are, and perform a SPECT CT if you're worried about infarction. The second phase is the cortical uptake phase, and you should assess the kidney visually for cortical defects. Use the time activity curve of the whole kidney region of interest with background subtraction, and you should have a normal peak between 3 to 5 minutes, which tells you that you've got normal tubular transit. If you're comparing serial studies, one tip I would recommend is to make sure that the scaling of your time activity curves on the y-axis is consistent. And also consider using some curve parametrics. So I'm not going to go into these in more detail, but there are some parametrics such as the 20-minute to 3-minute ratio, or the MUC10, which essentially tells you how much MAG3 has been taken up by the kidney in the first 10 minutes. And these parameters can be useful as a prognostic value in assessing your renogram, and also useful in assessing serial studies, so you can compare how well your kidney is functioning over time. The final phase in the renogram is the drainage phase. If you're worried about obstruction, then you should use a diuretic. You should see a normal exponential drainage curve with a peak to half peak time of between 5 to 6 minutes. We perform standing views because we find that can be useful to help drainage, and also post-micturition views are also very useful. If you are suspecting a urine leak, then it's, I think, important to do delayed imaging. And we found that performing delayed imaging 2 hours or even later can be useful. Obviously, remember, often the kidney function is not normal, and therefore it will take longer for sufficient volume of urine to be produced that will actually leak. You should always image the drainage bag if there is one, and also perform a SPECT CT if you're worried about any leak. So how do we put all of this together when we're interpreting the scan? Well, let's think about some of the complications. So you have early and late complications, early complications being hyperacute and acute rejection, transplant artery thrombosis, acute tubular necrosis, and urinary leaks or urinomas. Late complications are chronic rejection, ureteric obstruction, and drug toxicity. So if we look at acute tubular necrosis as the most common cause for renal dysfunction in the immediate phase, you'll find that actually 90% of patients with acute renal failure in the transplant is due to acute tubular necrosis, or ATN. And this usually occurs within the first 3 to 4 days and is related to ischemia of the transplant after harvesting and before the transplantation. It's estimated that 34% of cadaveric transplants and 9% of live donor transplants suffer from ATN. There are a number of risk factors for acute tubular necrosis, and these are things that the transplant surgeons and the renal team will be aware of. So if these are kind of on the request form, then that suggests that you're looking for ATN on your renogram. So when you're assessing the renogram curve for acute tubular necrosis, you will expect to see preserved perfusion, but not always. You will see delayed uptake and tubular secretion, and you will see a delayed T max and T half. So in this image here, you can see that there's delayed tubular secretion, and on the time activity curve, you have a delayed T max and T half of emptying and a high 20-minute to 3-minute ratio. With acute tubular necrosis, you get progressive accumulation of tracer within the cortex, and sometimes we get this picture of a slowly rising time activity curve with minimal or no bladder excretion. It's worth remembering that actually this is different from rejection, where you will often see some excretion into the urinary tract, and the progressive improvement in function and preserved perfusion help us to differentiate ATN from rejection. But it's difficult to differentiate often, and biopsy remains the gold standard for differentiation from rejection. In this case here, you can see the patient's got 2 transplant kidneys. On the right transplant kidney is an old kidney that is failing. You can see it's atrophic. The kidney on the left is the recent transplant kidney, and there is progressive accumulation of tracer within the transplant kidney and a slowly rising time activity curve. So renal transplant drug toxicity related to medicines such as cyclosporine result in normal perfusion but increased cortical retention with little or no excretion due to the poor tubular function. You can imagine from the description I've just given you that the findings on the urinogram are identical to ATN, and it's not possible to differentiate on the urinogram the two. Hyperacute transplant rejection. This is when you get absent renal perfusion and function within the first 24 hours of surgery, and it's due to venous thrombosis secondary to the recipient's antibodies to the graft. Acute transplant rejection usually occurs 2 to 3 months and is due to a cell-mediated lymphocytic infiltration. In this case, the renogram shows decreased renal perfusion as well as reduced uptake and excretion. You can see here that the function, the perfusion of the kidney is not as good, is impaired. The time activity curve and the area under the curve for the kidney is significantly lower compared to the iliac artery, and you have progressive accumulation within the kidney on the time activity curve, and there is some bladder excretion. With chronic transplant rejection, this is an antibody-mediated process that occurs beyond 3 months, and in this case, the renogram shows gradual deterioration of the transplant perfusion and function. You have minimal cortical retention only until very late in the disease process, and you'll see cortical thinning on cross-sectional imaging. Transplant infarction is something that's important to look out for in the immediate postoperative phase. You can have vascular occlusion, which occurs immediately postoperatively, and in this case, you'll have absent uptake on the postoperative scan, and this suggests arterial thrombosis. But you need to be aware of the transplant artery anatomy, because if you've got more than one artery, it's maybe hard to visualize thrombosis of a small accessory transplant artery. So check the op notes or speak to the transplant surgeon if you think if there might be a risk of infarction. Something that's also worth knowing is that the Doppler ultrasound may not be very sensitive in this situation, and you can't rely on that to interpret your renogram. So, for instance, if you think that there might be an infarction, don't be reassured by a normal Doppler ultrasound that was done in the immediate postoperative phase. I think if you are concerned about infarction, you should definitely perform a SPECT CT. So this is an example of a right iliac fossa transplant kidney with a single artery that was completely occluded, and you can see there's a photopenic defect in the right iliac fossa, which corresponds to this infarcted kidney. This is an interesting case. You can see in this right iliac fossa transplant kidney, there's a progressive accumulation of tracer. On the flow curves, there's good perfusion, or apparently good perfusion in this kidney. There's a progressively rising time activity curve, so you may say this is ATN. However, when you look at the images, you can see there's a very subtle flattening of the lower pole of this kidney, and that raises the suspicion of maybe there's an infarct that we're not seeing. When we perform SPECT CT, we can see clearly there is a large infarct, actually, that probably involves about a third of the kidney, the lower pole, but actually extends posteriorly much higher, and that is why we're not seeing so much of that on the 2D renogram image. This is another patient with a lower pole infarct. In this case, it's a more obvious, larger lower pole infarct. You can see the perfusion curves are greatly reduced, so the perfusion in that kidney compared to the iliac artery is much reduced. The time activity curve shows a slowly rising curve, in keeping with this ATN within the remaining upper pole, but you've got infarct in the lower pole. Now, in this case, the team wanted a contrast CT to look at the perfusion specifically and look at the vascular anatomy, and you can see quite nicely that there's these large infarcts within the kidney. Now, over time, the function improved somewhat, but it plateaued. And the question was, can we expect more function from this kidney? So we did a repeat renogram. It shows quite nicely how now you can look at the flow curves and see that the perfusion in that kidney is better. The renogram curve has started to normalize, so it's now peaking at the right time and starting to go down in the same way as a normal kidney. Also, you can see, just looking at the images, there's more perfusion and more uptake in the lower pole, but it's still heterogeneous. If we look at the SPECT CT that we did here, we can see why. We can see there's tracer retention in the upper pole, and that's the sort of normally functioning kidney. There's some reduced uptake in the lower pole, where there's some reperfusion in that kidney, but there's a large area in the interpolar region where there's absent uptake. So this is a persistent infarct. So although there has been some improvement in function and blood flow within the kidney, there's still a large infarct, which is likely going to limit the overall function of that kidney and also therefore the survival of that graft. A urinoma is where you have a leak of urine after the operation, and this can be seen as an accumulation of the radiotracer adjacent to the point of leakage. So it's usually around the location of the either the graft or the ureter or the bladder, and you should consider a potential urine leak if there are any postoperative perinephric collections. I think in this situation, it's essential to perform a SPECT CT, and also I think it's essential to perform delayed imaging. So we perform delayed imaging at 2 hours. Just be aware that when you are doing delayed imaging in patients with renal failure, you will see activity within the gallbladder and then in the bowel, and this can mimic a leak. As in this case here, you can see there's some activity in the gallbladder and in the bowel. This is a case where you can see on the planar image that there's tracer retention within the kidney. On the SPECT CT, there wasn't an obvious perinephric collection, but you can see definitely there's tracer activity within the drain. And when we image the drain bag, we can see that there's activity within the drain bag, and therefore that confirms that there's a urine leak, although there isn't a large perinephric collection. This is a more straightforward example of a urinoma, where on delayed imaging, we can see activity around the distal ureter. So this is the bladder, and this is activity in a urinoma around the distal ureter. This is an example which shows why it's important to perform delayed imaging. So on the early phase imaging, you see very minimal excretion of tracer, and therefore we don't see any evidence of a leak. But at 3 hours, we start to see more activity. It's activity in the bladder, and then you start to see this haze of activity around the bladder and around perhaps the distal ureter. When we did SPECT CT, you can see this localizes much more clearly to a small urinoma around the suprapubic area. Ureteric obstruction is another complication that occurs after transplant surgery. It can be due to intrinsic obstruction from clot, stones, or stenosis, or it can be extrinsic by compression from lymphoceles, hematoma, or abscesses. The transplant obstruction is often not very hydronephrotic, so don't expect the transplant kidney to be very dilated. If you are concerned about obstruction, I think it's important to perform a diuretic renogram in the same reason you would do in a native kidney, and the findings are exactly the same. In other words, you would see normal uptake with delayed drainage and an increase in T-half of clearance. You should use anatomical imaging such as a CT or ultrasound to try and identify the location and the cause of the obstruction. And sometimes you can't differentiate, you can't diagnose obstruction just on the renogram, and you might need to perform a nephrostomy just to make that diagnosis and confirm the diagnosis of obstruction. This is an example of an obstructed renogram. We can see here that there's a progressive accumulation of tracer within the renal pelvis, which appears dilated on this scan. And this patient had an obstruction of the proximal ureter. So just to summarize, there are 4 key take-home messages that I'd like you to remember. First of all, we can't differentiate acute tubular necrosis, rejection, and drug toxicity on a single MAG3 renogram. All have very similar appearances, and therefore it is not possible for us to sort of clearly differentiate. However, if we perform serial imaging, that can help us differentiate. With acute tubular necrosis, we would expect to see the function of the kidney improve. And I think another tip, if you can remember, is that if you are doing serial imaging, try and keep the y-axis of your time activity curve consistent between all your studies. If you're suspecting a vascular occlusion, and particularly in patients that have more than one transplant artery, they are at risk of vascular occlusion of one of those arteries, I would consider a SPECT CT. Now, you can either do the SPECT CT after reviewing your planar imaging, and if you are concerned by what you're seeing, you can do the SPECT CT, or you could even justify doing a SPECT CT on all patients with more than one transplant artery, given the high risk of vascular occlusion in those patients. The other thing you can consider is in patients that are suspected to have a urine leak, then I would consider doing a delayed scan at 2 hours. And we would always do a SPECT CT as well, because it's very difficult to localize a leak and differentiate a leak from physiological activity, either in the bladder or in the adjacent bowel or something like that. Thank you very much for listening to my presentation, and I hope you enjoy the rest of the study day.